welcome to the Phlebotomist's Playbook. If you're getting ready for your certification, you are in exactly the right place. We're about to dive into some of the most critical procedures you're going to face, and we'll focus on all those little details that really ensure patient safety and, of course, accurate results.
So let's just kick things off with a really important question. I mean, think about it. An error this big could easily lead to a serious misdiagnosis. In our field, precision isn't just, a nice to have. It's an absolute must. Keep this question in the back of your mind. We'll get to the answer very soon.
Okay, here's our game plan for this explainer. We're going to cover precision and glucose tests, nail down the difference between screening and diagnostic procedures, handle those tricky genetic and custodial samples, talk about timing for therapeutic drug levels, and then we'll wrap it all up with the absolute essentials for your certification exam.
All right, first up, glucose tolerance tests. Now, these are some of the most common procedures you'll perform, and let me tell you, they demand absolute precision when it comes to timing and technique.
It's so important to first understand the difference between these two tests. Think of the 2-hour postprandial, or PP, as a snapshot. It just tells us how the body handles glucose from a normal meal. But the glucose tolerance test, the GTT, that's more like a movie. It's this dynamic evaluation, showing us exactly how the body clears a very specific, concentrated glucose load over several hours.
So the 2-hour postprandial procedure is all about timing, timing, timing. You've got to notice that time zero starts the second the patient begins eating. For the next 2 hours, they have to rest completely. No exercise, no smoking, because honestly, any activity can change their glucose levels. And that final draw, it has to happen within this super tight 10-minute window, exactly 2 hours after that first bite. And there it is, the answer to our opening question. If a sample just sits there, unprocessed, the red blood cells will literally start eating the glucose in the tube. That process is called glycolysis. So that's why using a gray top tube, the one with sodium fluoride, the antiglycolytic agent, and processing it fast isn't just a suggestion, it is absolutely essential for an accurate result. Now, for a full glucose tolerance test, the patient prep, it's even more strict. They need to fast overnight, for sure, but just as important, they also have to carb load for 3 days before the test. This makes sure their body is ready for the glucose challenge and helps avoid a false positive. These instructions are totally non-negotiable for a valid test. Okay, let's walk through the GTT procedure itself. So after you've confirmed the patient has followed all the prep rules, you'll collect a fasting specimen. That's your baseline. Then comes the glucose drink. This right here is a critical timing point. The patient has only 5 minutes to finish the whole thing, and your timer for all the next draws starts the second they are done. Throughout the whole test, the patient has to stay at rest. Every single draw has to happen at the exact interval specified. And the labeling is absolutely critical. You have to label each tube right there at the bedside with the patient's info, the exact collection time, and the interval, like 1 hour or 2 hour, to create that perfect, accurate glucose curve for the doctor. It's so important to know exactly which test protocol you're performing. As you can see, a standard diabetes test uses a 75-gram dose. But for gestational diabetes, there's often a 1-hour screening test first, and that might be followed by a longer 3-hour diagnostic test if that screen comes back positive. You have to be aware of things that automatically disqualify the test. If the patient can't keep the glucose drink down, the test is invalid. Done. If a draw is really late or missed, the test is invalid. In any of these situations, your job is to stop the test, document exactly what happened, and let the provider know right away. All right, let's move on to Section 2, screening versus diagnostic tests. This really builds on our glucose knowledge because it's so important to understand the purpose behind each draw. Are you doing a general screen to just look for a problem, or are you doing a diagnostic test to confirm one? The Oral Glucose Challenge Test, or OGCT, is a perfect example of a screening test. It's often that first step in checking for gestational diabetes. Notice the key differences here. No fasting is required. It uses a smaller 50-gram dose of glucose, and you only do 1 draw at the 1-hour mark. All it does is flag patients who might need to go on to the full diagnostic GTT.
Okay, pay close attention here because this is a classic exam topic. You will almost definitely be tested on the difference between a screening OGCT and a diagnostic GTT. Just remember this. The screening test suggests a problem. The diagnostic test confirms it.
Now, the lactose intolerance test looks a lot like a GTT. You've got a fasting baseline and timed draws, but the whole purpose is completely different. Here, we give the patient lactose, not glucose. We're not testing their insulin response, we're testing their body's ability to break down lactose into glucose. If their glucose level doesn't go up, it points to a lactase deficiency. Mislabeling this test as a GTT is a major error. Okay, let's shift gears a bit and talk about collections where the stakes are incredibly high. With genetic and chain of custody samples, a tiny mistake in how you collect or handle it can have massive legal and personal consequences. The type of test dictates the exact specimen you need. For inherited diseases, a lavender top tube is usually the standard. For paternity testing, a simple cheek swab is pretty common. And for newborns, it's that familiar dried blood spot. The most important thing to take away here is you always have to use the exact container that's specified for that test. This right here is one of the golden rules you absolutely must know for your exam. Heparin, that's the anticoagulant in green top tubes, it completely blocks the PCR reaction that's used in most genetic tests. If you use a green top when you're supposed to use a lavender top, that sample is going to be completely useless. This is a guaranteed exam topic. For any test that has legal implications, we're talking paternity tests or forensic analysis, you have to follow a strict chain of custody. This isn't just about collecting a sample, it's about creating this unbreakable, documented trail. From verifying their identity with a photo ID to sealing the specimen and logging every single person who touches it, every step has to be perfect. Okay, in our final section, we're going to cover therapeutic drug monitoring, or TDM. And here, your timing as a phlebotomist is just everything. It doesn't just affect a lab result, it directly guides a doctor's decision on a patient's medication dose. And if you get this wrong, it can lead to toxicity or the treatment just not working at all. The whole foundation of TDM is just understanding the difference between a trough and a peak. The trough level, think of it as the lowest point of the drug in the bloodstream, is drawn right before the next dose is due. It tells us if the patient has enough medication in their system to still be effective. The peak is the highest point, drawn a specific time after the dose, and that helps us check for potential toxicity. Just look at how specific the timing is for different drugs. For an antibiotic like vancomycin, the trough is drawn right before the dose. But for a heart medication like digoxin, you have to wait at least 6 hours after the dose. And for lithium, it has to be at exactly 12 hours. You absolutely have to know these specific rules for your exam. So here's the bottom line. A TDM lab value is completely meaningless without context. You have to meticulously document two things: the exact time of the last dose and the exact time of your draw. Without those two timestamps, the lab can't interpret the result and the doctor can't safely treat the patient. It's that simple. Okay, let's lock in the key takeaways for exam day with a really quick review. When it comes to glucose testing, it's all about timing, tubes, and purpose. Remember those strict schedules, the gray top tube to stop glycolysis, and the difference between a diagnostic GTT and a screening OGCT? For special collections, really focus on those critical errors. Remember, heparin inhibits PCR, so use EDTA. For chain of custody, know the 4 key steps: positive ID, consent, tamper evidence seals, and that all-important transfer log. And finally, for TDM, just commit these definitions to memory. Trough is before the dose. Peak is after. Know the specific rules for high-risk drugs like lithium and digoxin. And never, ever, ever forget to document both the dose time and the draw time. As you keep studying, always bring it back to this. Mastering all these details isn't just about passing an exam. It's about the promise we make to the person behind every single sample, making sure they get the accurate diagnosis and the safe treatment they absolutely deserve.